Okay. So good afternoon, everyone. I thank Dr. Rishikesh for the wonderful presentation. He has actually made my job simpler. So I'll be talking about the practice-changing news in renal and hepatology. So in nephro, we will talk about imaging, renal replacement therapy, biomarkers, and newer drugs. So firstly, coming to the most important development is the VEXAS, as Dr. Rishikesh has already said. Organ congestion is associated with adverse critical care outcomes in ICU. So these Bubin and colleagues developed a grading system to assess the severity of venous congestion, and it was validated for its potential to predict AKI in post-cardiac surgery patients. So in this cohort of cardiac surgery patients, as we can see, this combination of IVC more than 2 centimeters, IVC diameter more than 2 centimeters with multiple Doppler abnormalities of severe Doppler abnormalities was associated most strongly with the prediction of AKI. And here they had a high specificity in predicting AKI, that is around 96%, but a low sensitivity. And this was when adjusted with pre-operative AKI risk score and vasopressor inotrope score, it was still significant. So when this VEXAS was also used in general ICU cohort patients, it was also found to have a predictive ability to diagnose major adverse kidney events in detecting and with hepatic and portal venous Doppler abnormalities. In a VEXAS scan of cardiorenal patients, in about 180 patients, this is a study published from India, it was seen that a combined grading of the IVC hepatic vein and the portal vein reliably demonstrated venous congestion, and there was a dynamic association, that is the grade of AKI correlated with the grade of VEXAS, and with improvement of VEXAS score, the AKI grade also improved. So POCUS can also be used for assessing the etiology of AKI. Hemodynamic or pre-renal AKI will lead to hypoperfusion due to either hypovolemia or due to low oncotic states like the heart failure or liver. Here, when we assess the LVOT, that is left ventricular outflow tract velocity time integral in echo, here if we see that there is a low cardiac output, then it is a it indicates to the cause of hemodynamic or pre-renal AKI, as compared to high cardiac output, which is seen in distributive shock, likely sepsis, where the AKI is not likely to be pre-renal. So intrinsic renal AKI, how can we diagnose that? By the most important parameter here is the renal resistive index. It measures the resistance to flow and it assesses the microvascular perfusion of renal arteries. Here, it is obtained at the level of the segmental arteries. The peak systolic velocity minus the peak diastolic velocity, and by peak systolic velocity gives a measure of renal resistive index. Here the normal values are less than 0.6, cutoff is more than 0.7 for detecting high renal resistance. So this may be renal resistive index may be increased in AKI in conditions of intrinsic renal disease like rejection, hepatorenal syndrome, or acute tubular necrosis. And it also correlates well with diagnosed ATN in over 90% of patients. So coming to the next modality which has come up is a contrast-enhanced ultrasound for assessment of renal perfusion in critically ill patients. Here microbubbles formed of phospholipid bilayer and with a core gas. So they are infused. They have rheologic properties like RBCs. They can be deformed by the microcirculation. They deformed when ultrasound waves are directed, they are deformed by the waves and they reflect signal, and it is utilized to study the microcirculation. This is a normal B mode imaging of the kidney, and when we put contrast, the imaging of the vasculature becomes more accurate. So with the different parameters like mean transit time and relative blood volume, these are the parameters which assesses blood flow velocity and the blood volume in the kidney. We get a single marker, that is the perfusion index, which gives a estimate of how perfused the kidney is. So it has been seen that this perfusion index is low in cases of cortical perfusion in septic shock. Cortical renal perfusion has been seen to be decreased in septic shock, and parameters like mean transit time, which predicts the rate of flow of blood into the renal arteries, they are also found to be low in higher stages of septic shock with AKI, higher stages of AKI. So what are the future prospects in contrast enhanced ultrasound? It can help us in assessing the intrinsic renal microcirculation to assess venous congestion and splanchnic perfusion. It can help us in prognostication of AKI in regards to requirement of renal replacement therapy and assessing renal recovery, and it can also help us to provide goal-directed therapy to prevent or ameliorate AKI. So coming to the drugs that are used, that has been used in the last decade. So what is the role of bicarbonate in metabolic acidosis? Does it help? This question was raised in the BICAR ICU trial, where infusion of isotonic bicarbonate resulted in, although it did not reduce the composite outcome, which was mortality and more than one organ failure at the end of 1 week. However, it reduced the requirement of dialysis or renal replacement therapy in patients with severe metabolic acidosis. Also, the secondary outcomes like use of renal replacement therapy during in the ICU free days was reduced, and also the mortality in the predefined subgroup of a higher severity of kidney injury, that was also reduced. So when should we start renal replacement therapy? What does the current literature say? After the ELAINE and the AKI trials came the START AKI trial. Now this looked into the same question, early versus late. Here also accelerated strategy, that is RRT started within 12 hours of diagnosis of AKI, severe AKI, that is KDIGO stage 2 or 3 with kidney dysfunction in critical ill patients. Accelerated RRT did not result in any mortality benefit. It required higher dialysis in the patients following ICU, and also resulted in non-serious adverse events significantly higher. So when should we do renal replacement therapy, early or late? What is the ideal time? This was studied in the IDEAL ICU trial. That was also another multi-center controlled trial where patients were included with rifle failure stage criteria with septic shock. But after diagnosis of that, the delayed strategy, here the patients were waited for 48 hours or till any emergent indication occurred. So here also in the late group versus the early group, there was no differences in mortality, and the delayed strategy did not help actually. So what is the jury then? Should we do RRT early or late? According to the 4 important trials in the last 6 years, only ELAINE trial had actually shown some mortality difference, which was mainly done in surgical ICU patients. The AKI, IDEAL ICU and START AKI all have shown no differences when RRT was started early versus late. So coming to the next question, so how late is too late? How long should we wait? So in this study, this was again a multi-centered trial, randomized trial, where they included higher stages of AKI, KDIGO, that is oliguria more than 72 hours, and with blood urea nitrogen of more than 112, and stage 3 KDIGO. And one group was waited till there was any emergent indication like metabolic acidosis, hyperkalemia, pulmonary edema, or the blood urea nitrogen had gone up to 140. So in the more delayed strategy, there was no difference in mortality, but the more delayed strategy had indicated that it could result in potential harm, because there was a hazard ratio in the secondary outcome. The hazard ratio was more for the delayed mortality. So this AKI 2 trial, which showed us that a very late strategy may be harmful, that was really because urea is not an ideal trigger for RRT initiation, and urea is affected by several factors, and many of the patients, that is 33% patients in the delayed strategy group, more delayed strategy group, actually had required RRT before the criteria got fulfilled. So we need more robust and validated tools that discriminate between patients with AKI who will mostly need and benefit from starting RRT in the late group than those in whom it can be avoided. So coming to biomarkers in AKI, what is the how should we use it? So the new proposed definition of acute kidney injury according to the Acute Disease Quality Initiative Consensus Conference that was published in 2020 in JAMA, they have subdivided the stages of AKI according to the KDIGO by incorporating biomarker classification. That is, subclinical one stage is without any difference in creatinine or urine output, but with biomarker positive. This is a place where we can diagnose AKI early and we can actually intervene to prevent progression. Then comes the A and B stage, where the biomarker is negative and positive respectively with the criteria for stage 1. Stage 2 again with negative and positive, and stage 3 with negative and positive. So with a biomarker positive and with a clinical criteria of KDIGO staging, the prognosis becomes worse. So, and also when the biomarker has come negative along with the resolution of the creatinine and urine output, then we can call it a proper resolution. So it also helps in detecting resolution. So AKI predictor has been developed as an online prognostic calculator. This has been published in 2017, and the authors have taken the large database from the multinational EPANIC database, which was done for the nutritional assessment study. So from this database, a model was developed in 2,000 patients, and the model was validated in another 2,000 patients. So here, the predictors that became significant were age, baseline serum creatinine, diabetes, and type of admission in both medical, surgical, emergency, or planned admissions. So they had built two models, AKI 23 and AKI 123, and these models were found to be better predictor with better accuracy with higher area under the curve of ROCs. So as compared to NGAL, that is one of the markers of tubular injury. So this is one of the upcoming AKI predictors that can be done with only clinical markers. So how should we incorporate these biomarkers in the diagnosis of AKI? As we have seen that the classification of AKI has been modified with incorporation of biomarker, but how should we do it? So combination of biomarkers are advised, like neutrophil gelatinase associated lipocalin, NGAL, which is a marker of tubular injury, and a combination of two key proteins, that is for tubular cell cycle arrest, like insulin-like growth factor binding protein, IGF-beta, and tissue inhibitor of metalloproteinase 2, that is CIMP2. So when we combine these, we get a better assessment. NephroCheck is a combination of these two tubular cell cycle arrest markers, which has been approved by US FDA for early diagnosis of AKI by measuring their urinary samples. Now, in this definition, Bellamy et al. Has proposed for incorporation of the biomarker value along with the clinical staging. That is more than 2 times of the tubular cell cycle arrest markers elevation, or elevation of NGAL value of more than 100 nanograms per ml. And subsequently stage 3, NGAL more than 100 to 150, 150 to 250, and more than 250. And along with the cell cycle biomarker values. So what is the future of diagnosis? We have to subphenotype AKI according to biomarkers, and we should also go for various progression models in machine learning to know which is the ideal model that we follow. We have to look into the markers of AKI duration. Progression and recovery models as well as biomarkers will tell us how long will the AKI last. And markers of AKI severity with machine learning, real-time GFR assessment, automated urine output measurements through some stress test, biomarkers of injury and stress, as compared to the current AKI diagnosis. Variety of drugs has been used in the pathophysiological processes that impact development and progression of AKI. For example, drugs for hemodynamics and oxygen delivery, cellular metabolism, cellular repair, fibrosis, inflammation. So among them comes the ATHOS trial, where angiotensin 2 has been used, and it was seen in the ATHOS 3 trial, it helped in improvement of renal function and improvement of hypotension. So tepasiran is a micro RNA which can prevent cell death by P53 mediated cell death and can help in recovery of injury cells. In a small cohort of cardiac injury patients, cardiac surgery patients, it was also found to prevent progression to AKI. So coming to the hepatology update in just a few minutes, I'll complete. So drugs in acute and chronic liver failure, new definitions and extracorporeal liver support therapies. Albumin, how should we use it? So daily infusion of albumin to maintain a target albumin level of 3 grams did not improve outcomes in cirrhotic patients. This was the confirmed trial where terliparatine and albumin actually could reduce progression of HRS1 and could reduce the requirement of renal replacement therapy, so this should be used. GCS if in acute on chronic liver failure, it does not help when founding multicentric randomized control trial as compared to previous single-centric and case reports. N-acetylcysteine role in non-paracetamol ALF, a small RCT had actually proven its role, although with limitations, but it is now routinely used. So we should consider it, although without much evidence. Hepatorenal syndrome, as compared to the old definition, the new definition has incorporated, according to the KDIGO, it has incorporated the, it has removed the creatinine criteria and has incorporated the new definition of AKI by the, So next, coming to high volume plasmapheresis, it has been in a multicentric trial of transplant in ALF patients. It has shown to increase the transplant-free survival and has attenuated immune activation and multi-organ dysfunction by studying they have found it by studying the immune markers. So this has led to incorporation of level 1 evidence of grade 1 recommendation of plasma exchange in ALF patients in the EASL guidelines in 2017. The extracorporeal liver support therapies, MARS is the overall most useful option to reduce mortality.
Dr. Sulangna, I think it's time.
Yeah.
You overshot the time, madam.
Yeah, thank you.